All right, so does anybody remember the 3 types of strokes that we talked about? There's 2 that are very well commonly known, and a third, which is very rare that your book doesn't even mention, but it's the type my dad had, so I always put it in the lecture because if it happened to my family, it happened to anybody. Oh, or Faith, what's one type? Ischemic? What is ischemic strokes? What causes an ischemic stroke? A blockage by what? Right, that's a stroke. And that's what a stroke is not getting oxygenated blood to the brain. By which way that is not happening, it determines which type it is. So ischemic was a blockage, which is what? A blood clot. It's a blood clot that has gone somewhere into the brain, into an artery, whichever, and has blocked blood flow to the brain. Okay? What was the other type? The big hemorrhagic. Okay? Or rupture. What is that one? What is causing that? A bleed. It's a brain bleed. It's not, the brain is not getting blood because it is bleeding outside of where it is supposed to go. Okay, does anybody remember the last type, the really less common one? Huh? Kind of. It starts with an H. It's called a hypoxic stroke. This is strokes that is caused by not getting enough oxygen from breathing. It can be one really common type or cause is CO2 poisoning, stuff like that, where the blood, it's pumping to the brain, okay, but the blood is not carrying the oxygen because it's not getting it from breathing. Okay? All right, so I want to give off some terms here to make sure that we're all on the same page of what these mean in order to make this lecture make a lot more sense. The first one is hemiplegia. Hemiplegia is weakness or paralysis on one side of the body, but it's a significant weakness. This is like barely any trace of muscle at all, like movement, very, 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 very weak. Okay, that is hemiplegia. Hemiparesis it affects the same side or one side of the body as well, but it's a milder case of weakness. You can tell that it is a lot more weak than the unaffected side, but it's not like where they can't completely move it. They have some strength in it. Okay. All right, hypertonicity or spasticity. That is like an abnormally strong muscle that is resistant to stretch. It's where they get really spastic. Okay. I know we've talked about what spasticity is before, but I want you to know what a arm looks like. So I want you guys to do this with me. Okay. So we're going to get to these movements. First one's a little bit harder to do. The rest of them will make more sense. We're going to do these all simultaneously. And this is what a spastic arm looks and feels like to the patient all the time. Okay. So you want your scapula slightly adducted. So it's going to rotate inward, right? How do you do that? By kind of abducting your arm, right? All right, so the next one is externally rotate your shoulder just a little bit. Okay? Now slightly abduct your arm. Okay? We good? Jennifer, are you with us?
No, I was still right.
Okay. Adduct your scapula. So, okay. Externally rotate your shoulder and slightly abduct your arm. Okay? Flex your elbow. Okay? Flex your wrist. Supinate your forearm. And fingers are flexed. Okay? This is what a spastic arm feels like to the patient all the time. And it doesn't move. It is stuck like that all the time. How uncomfortable is that, right? And it won't move. You can't stretch it out. Nobody can grab and move your arm. It is spastic. It is resistant to you stretching it. You can normally get some movement, but it's not much. Very, very little. It takes a lot of work when a patient has a spastic arm in order to get it, starting to move again. If someone is spastic, what are they at really high risk for? Contractures, and then it's locked. It's a different ball game. Very good. All right, so again, the different types of strokes is the ischemic. Remember, that is the clotting stroke. A hemorrhagic is where a blood vessel bursts or ruptures or leaks. And then the hypoxic stroke is the not getting enough oxygen from breathing. The way that I want you guys to start thinking about a stroke and the way that we like brain anatomy is more or less a road. Okay, your brain is constantly sending signals out to muscles, to organs, whatever it be, and trying to get it to work. Right, it's the main center that's sending all those out. Well, think of it like a mailman. Okay, on a road. They're trying to deliver this package or the message or the signal to whatever muscle or body function that it is, and now it's trying to cross a bridge. A stroke is if you just took the bridge out, okay? The mailman's still getting sent, more or less, but it's dropping off. There's nowhere for it to go. It's stopped. So that area of the brain is more or less dead. It has stopped working in that small function or that small piece, okay? So when you think of what a stroke does and how we recover that is that whole idea of neuroplasticity, where your brain can kind of rebound and rebuild, right? So what would be your way if a bridge fell down? How would you repair that? Just with common sense thinking. How would you do it, Isaiah? Build a separate bridge around it. That's what your brain does. Okay, it builds a new pathway. Okay, that is the whole idea with stroke recovery. Now, how we get to that point of building that new bridge to make it a successful connection again and get that muscle working, get that function back, that's what we're going to talk about the majority of today is what happens with therapy. How do we get to that point to make that new type of connection? Okay. Doesn't always. My dad had none at all. It depends on where the stroke was in the brain. Why is that like the common? Well, I mean, you got to think of how your brain works, right? It's a common, or it's a whole system that's working together. You cut it off, it's a major thing, right? Until you have a new detour, right? I really like to think of stroke recovery in like terms of like road construction because it just kind of makes sense. There's literally something trying to get sent out, it can't. So they have to build something around it in order to get you where you're going. That's stroke recovery. Now, if motor is affected, and you can look, we're going to go through the different what is affected and how it's affected a lot today, but there's a lot of different reasons for that. It depends on where the area of the brain. Some people will have one entire side that is affected. Some people won't. Some people will just have weakness. So, and it really just depends where the injury was in the brain. Okay. All right. So some common effects of strokes are neuromuscular and motor or movement related functions are affected. Sensory function is affected a lot. Perceptual function, mental cognitive functions, emotional and behavioral functions, and language and communication. It can literally affect anything in the whole body. Every stroke patient is different. They all recover at different paces, and they all appear totally different. This is truly one of those cases that if you see a patient who has had history of stroke, it doesn't matter how far out they are. It doesn't matter how close they are to the injury. It doesn't matter age or anything. Every single person is going to be 110% different. Okay? You might find some similarities, but I promise you're going to find something that is different. Brain injuries are just that way. There's no way, there's not really a rhyme or reason of, this is definitely going to affect this, but, you don't take into account what the person's emotions and stuff were beforehand, how their personality was. That's really tough for a lot of patients. Like I said, when my dad in his stroke recovery, his personality totally changed. He had no physical stuff. His balance was fine, all of that. His was all, mental issues. He had a lot of depression. His anxiety was crippling. We had to teach him how to do everything again, but there was not a physical reason for that. See, a lot of people treat strokes for teaching people how to bathe and dress and all that stuff again, but You know, in my dad's case, his was he didn't know how to do it. It's not that he couldn't do it, he didn't know how. He would just stand in the shower and let water hit him. But he had no idea to pick up a washcloth, put soap on it, you know, wash his body. That all had to be retaught to him. The best way that I like to describe him, not being mean, but in a real sense, was he was like a toddler that had dementia. I mean, he really was. He couldn't remember anything. Anything we tried to teach him, he would forget. He acted like a kid. It was you know, pretty wild to see, you know, my dad. And he was a very independent person through his entire life. To give you an example, we went to WVU to get a specialist opinion. And after we didn't get a really good report and all this stuff, and his favorite place in the world to eat is Chick-fil-A. So we stopped at Chick-fil-A in Morgantown, right outside the hospital. And my dad is 6'4" and like right at 350, 600 pounds. He's a big dude. And he tried to crawl into the booth at Chick-fil-A and lay down and take a nap. So just to give you an idea of what behavior changes can go from, I mean, he is a massive, massive dude, and he is trying to sleep in a booth in Chick-fil-A, in a crowded Chick-fil-A. So, you know, that social cue stuff, all of it was completely gone. On the way there, I had him ride in the passenger seat. He tried to grab the steering wheel to run me off the road. Just totally bizarre behaviors. But, you know, he had presented totally different than any stroke I had ever seen. It wasn't even remotely close. I've never seen anybody have a reaction like he did. All right, so let's talk about some complications that are caused by strokes. Bony contractures, that's just meaning like contractures over where bony prominences are, like your fingers and stuff. Those contractures are very common. Just deconditioning, a lot of times you're going to have that as a goal or in the treatment plan to treat deconditioning with stroke recovery. What is a deep vein thrombosis? Does anybody know what that is? It's DVT. A lot of people just call them DVTs. Yes, right. It's a clot. It's a blood clot. What do you normally hear DVTs caused from? Spider vein can be that poor blood circulation. Normally, yeah. A lot of people, when they go into hospitals, are at risk for DVTs because they're laying in beds for so long. Have you ever seen the compression things that they put on people's legs in the hospital that constantly blow up? And that's to keep blood flow going. That's to keep those blood clots from happening. But patients with strokes, if they don't have movement and they are paralyzed on one side, you know, there's not ample blood flow because your muscles aren't contracting, you're not moving it, so you're at much higher risk for blood clots. So if you have a patient who you notice a large red hot area developing on their leg, that is a medical emergency because that can cause them to have another stroke. If you start moving their leg and they have a clot, you can kill them. So it's very important that if you see something like that, that's an emergency. You need to go get a nurse, whoever, get them the medical care they need. Okay. A lot of times if patients have DVTs, they're not allowed they won't let them out of bed until they get the clot fixed. They break it up with ultrasound or medications or whatever. They won't let them out of bed a lot. Sometimes they do, but I always err on the side of caution, like, no, let's work in the bed today till this is taken care of. Dysphagia, remember that's swallowing, issues with swallowing. Emotional changes, they're at high risk for falls, high risk for osteoporosis, seizures, skin breakdown, and UTIs. All right, so let's talk about some of these treatment approaches, okay? These are really, really, really common, and you need to gold star the crap out of these, okay? So these are all old frames of reference for stroke rehab for motor impairment, okay? These are older things, but literally I can't think of anything that would fall outside of these four, or these, we're going to go over a fifth one, but these types, okay? The first one is the neurodevelopmental treatment, or the NDT method. This was developed in like 1940 or something like that. But it's all about repeating normal movement patterns and using things like key points of control. So where is the most centralized point of control in your whole body. This is kind of like a review from kinesiology. What is like the most center point of control in your body? Like, what is one of the more basic things that you have to be able to do? Think of posture. Core, trunk control. Absolutely. That's one of the more basic things that has to happen. But NDT always looks at key points of control. All right, so the PNF, or the proprioceptive neuromuscular facilitation approach, or you'll always hear me call it the PNF. This is where they use the body's proprioceptive system to facilitate or inhibit muscle contractions, but it moves in a diagonal pattern. One really common thing that you'll see with PNF is like brushing your hair. That's in a diagonal pattern. See how your arm bent in a normal pattern, but it's in a diagonal. Okay, so when you think of PNF, I want you to think of diagonal movement patterns. We good on those two so far? Okay, so the Brunstrom, this is where they use primitive reflexes to help facilitate muscle groups. This one, Brunstrom's approach, they believe that you go through like a stage of motor recovery, through different stages in motor recovery, but I want you to remember it as like primitive reflexes. Okay? So when I say a primitive reflex, what am I talking about? Think about your pediatric stuff. Right. You're where I'm wanting to go with that. Do you have to think about reflexes? No, your body does it. That's why it's called a reflex, right? So they're using those primitive reflexes to facilitate movement. Okay, this is when someone's like flaccid and they're wanting to use a reflex of some type to try to inhibit a motion or a movement that you don't typically see, that they can't do by themselves, but they can respond with a reflex and get a movement. Does that make sense?
Reflexes. The neurons for reflexes in the spine.
That's outside my pay grade, buddy. I don't know. Maybe. Maybe.
Think about like a stroke doesn't make your reflexes go away, so I'm assuming they're not in the brain.
Well, it can, but what it's using is the most primitive form of movement is a reflex, right? I throw something at you, you dodge it. That's primitive. You don't need to, I'm not saying throw stuff at stroke patients, but you know what I mean? Like you're going with the most primitive form of movement to start out with movement first. Okay? Are we good on that one now? Okay, cool. And then the root approach. This is where they use sensory stimulation to help facilitate muscle contractions. But it's all about facilitating contractions and inhibiting muscle tone. Okay? Those are the four, or we've got a fifth one, but those are the four big ones. Are we good? All right, good deal. All right, so let's talk about what motor learning is. Go to page 849 in your book, please. Well, hang on. Go to page 842 first. I want you guys to highlight this table. I think it'll be really helpful for you guys for understanding strokes. It's table 33.2, but it's areas that are typical of or deficits that you see with the left and right brain stroke. Okay, so going over a couple of them, a stroke on the right side of the brain often results in the left side hemiparesis. Now, you know that is the opposite. I probably should have premised that off. If you have a stroke on the right side, the left side is affected, and if you have a stroke on the left side, the right side is affected. It's opposite. Okay. One that is kind of sticks out is you see a left side stroke. They have that aphasia, bilateral motor apraxia. There's some different ones that kind of stand out. So, if you're going to see that on an evaluation when you see stroke. It might say history of CVA, but they'll clarify if it's a left or right because it's going to present differently. Okay? All right, so anyway, let's go to page 849 now. All right, so what is motor learning? It is how a person practices a skill affects how quickly and how well the person learns a skill. So motor learning is literally trying to teach the body again how to move in a normal way, how to perform a task in a normal way that they always did, right? There's a few practices that I'm going to actually have you guys read real quick. Who wants to volunteer? Then I want you to explain it, how that works. Okay. The first one, again, is the first one is mass practice versus distributed practice. It's on 849. Who wants to volunteer to read number 1 for us? Maggie's got it. Okay, so what, in a nutshell, what does that mean, Maggie? Yeah, what is that mass practice versus distributed practice? What does that mean? Okay. Well, mass practice is not taking breaks. Distributed practice is taking breaks. Well, it's few, but it's more like a sprint than it is a marathon with mass, and vice versa. Well, that's what I want to do with this is I want you guys to think of an intervention now that matches that principle. Okay, so a mass practice again is doing something continually, practicing with few rest breaks. Distributed practice is when there's multiple rest breaks in between, like different trials of something. So can you think of an intervention you would do with a stroke patient that fits either one of those? I don't care, just give me an example. Yeah, because there's less resistance. That's a good idea. Yeah, I like that idea. So doing some type of an aquatic therapy. Okay. So that's a mass practice example. What would be a distributed practice example? Don't overthink this. This is not something way out there. This is doing something like pretty much straight through with very few rest breaks, or doing something and breaking it up, giving them rest breaks. So what would be a distributed practice? I didn't hear you. What? Okay. See, with stroke recovery, that happens with kids too. A lot of people don't think that, that in the pediatric, but there's a lot of strokes that happen, to kids. It's a lot more common than people think. So give me an intervention, like a specific intervention that you might come up with that you take breaks. Okay. Okay. So let's break that down even more, because you're talking about somebody, we'll talk about a fresh stroke. They have very little activity tolerance. So cutting the vegetables. Okay. Okay. So do that same intervention now with mass practice, and what would it be? That's exactly right. Does that make sense? So thinking of a specific intervention and how you're going to practice it makes a huge difference. Now, which one do you think is more beneficial? The book kind of told you. Which one has like what's like the goal, I guess would be a better way of putting it than the mass is a little better because you're pushing them a little further. It takes more effort for them to go through with, we'll stick with the washing vegetables thing. It takes more effort to wash the vegetables, cut them, do this, than it does to just watch the vegetables, take a break. Very good. All right. Who wants to volunteer for variable practice versus constant practice? Isaiah, it's yours.
Variable practice is when one piece of the practice is altered in some way, using different cup sizes to drink from, as practice grab and release. An example of variable practice. Constant practice is practicing the same thing in the same way. Variable practice is thought to be better for motor learning. For different types of practice, the motor system is forced to problem solve in new ways and thus adapts readily to newly learned ways.
Okay, so with variable practice, I love the example the book gives where it's like different size cups. Pick up this size, pick up this size, pick up this size. Okay, constant practice would be, okay, pick up the coffee cup, put it down. Okay, pick up the coffee cup, put it down. That's constant. Okay, so think of an example. Lindsay, give me an example of what constant practice versus variable practice would be. Give me another intervention. Okay. Okay. Walk me through it. How does each one went? What?
For the constant, you would do like a basketball, and then for the variable, you would do like a tennis ball.
Exactly. That's exactly right. Perfect. Everybody got that one? Kind of makes sense? All right. Allison, you want to do number 3? Okay. Sorry. Okay. So either doing the entire thing or just performing a piece of it. Okay. Now it's different because it's not like taking a rest break. It's like that's your intervention, doing a part of it. Does that make sense? So, Maggie, give me an intervention here. Okay. Exactly. Perfect. That's exactly right. Good job. Did everybody hear? I know it's hard to hear. I can't ever hear Maggie. But we're good on that one? All right, cool. Number 4, Cassidy. Okay. So Faith, give me an intervention that you can do either way.
I guess I think of cooking again, like we talked about the vegetables and random practice.
So block, it's not necessarily the whole or part, it's the same thing over. So like the example that they gave of, it's like a field goal kicker constantly kicking a field goal, right? That's all they're doing the whole time. Random practice would be like kicking the ball, and I know this doesn't make sense in football, but like catching the football, running, like there's a lot of different aspects other than kicking the football, right? So it's constantly doing the same thing over, but it's the same thing. Random practice is adding in all the other pieces and randomly practicing. So you might kick the ball, you might do this, go back to catching or kicking the ball. Does that make sense? It's kind of bouncing. All right, are we good with those? Yeah, makes sense? Cool. All right, so what is feedback? When we're talking about feedback with stroke recovery, what do I mean? This is super important for stroke recovery too. Huh? Yes, okay. You have to talk to your stroke patients, okay? You have to let them know what they did right, and you have to let them know what they did wrong. If they don't know that what the action that they're trying to do is incorrect, if it was an awkward movement pattern, if they skip some steps, whatever, you have to let them know what they did wrong. And feedback is super, super important because you don't want somebody learning how to do something incorrectly because you have to think of it, you're literally teaching them to walk, talk, bathe, whatever again, right? They don't know how to do it. So it's like if you were, teaching, I hate to keep using the child aspect, but if you are teaching a child how to do something, you want to teach them how to do it right. You know what I mean? Same thing with stroke recovery. You want to teach them how to do it correctly and safely. All right. So there are some, the intrinsic and extrinsic stuff that I think we're pretty good with. That intrinsic is feedback from themselves. Oh, I feel like I did this horrible, that kind of stuff. Extrinsic would be you or someone telling them they did something wrong. Are we good on that concept? Okay. Which one do you think is more important? Or are they both important? Isaiah, what's more important, intrinsic or extrinsic feedback? Okay. Why? You're right. But why? Why did you lean toward extrinsic with strokes?
Well, there's a lot of just brain confusion.
Mm-hmm.
So I was thinking, and also them not being aware of the rules or maybe forgetting rules of society or the task they're doing or whatever. So
right.
They need someone outside who knows what's going on.
Very good. Exactly. It's not even. I like the word that you said. There's a lot of brain confusion going on. There's a lot of they don't know what right and wrong is. They may have their own perception of what right and wrong is, but it might not necessarily be right or wrong. So it's really important that you are that anchor of this is how you take a shower. This is how you put on your pants. This is how you go to the restroom. Whatever it is, you are the constant giving them feedback. All right, cool. There's another approach that I want to talk about that's really, really effective, and I've used it a lot. It's on page 850, so you can see a picture of it. But it is the constraint-induced movement therapy, or CIMT. This is super, super helpful. It sounds awful because it says constraint, but it means forcing them to use that affected extremity. Because every stroke patient is going to try to compensate with whatever extremity was not affected the first time. It doesn't matter if they were right-handed and the stroke affected the right side. They're going to start trying to use their left hand way, way more to compensate for what that right hand can no longer do. But that doesn't help rehab the right extremity, right? We're completely ignoring it now, and that's not what we want to do. We want them to try to push to use that. We want normal movement patterns. Or normal movement and normal task completion. So look at page 850 in that picture. You see what she has done with this stroke patient? Lindsay, what is she doing? Yeah. Right. Because his body is not, what is going to be easier to pick up? It looks like those starbursts. What would be easier to use? Can you pick up starburst in a mitt? No, it's literally forcing his body to use the affected extremity because now that option is easier. Does that make sense? So it's constraining the unaffected side and more or less forcing them to use the affected side. Okay? All right. The next one is bilateral training. This is where you are not restricting anything, but you are asking them and having them use both extremities to complete a task. So you may have them do something as simple as, use your left hand, which we'll say is the affected hand, to hold the paper. Use your unaffected to write your bills out, whatever it be. Use your left hand to hold the vegetable while you use your right hand to cut it. Those kind of things. You're asking them to use both hands to do some type of a intervention. Okay? All right, and then we have talked so much about what weight bearing is, but I don't know if we've ever actually shown you weight bearing before, have we? Like what it looks like, what it's supposed to look like. Okay, so what is weight bearing? Jennifer, what's weight bearing? Right, I should have used you a little bit. That's a weight bearing precaution, but what is weight bearing as an intervention? Cassidy, you know it? Right, exactly. So look on page 852. That picture in the top left-hand corner, that's what weight bearing as an intervention is. Why is weight bearing important with stroke recovery? Without me telling you why, think about it. Why would that be good for somebody? So his left extremity is affected.
Just pushing down on that?
He's leaning on that arm. So he's just bearing weight. That's all he's doing is putting his body weight through that affected extremity. Why would that be beneficial? Why is that important? Well, I mean, that's long-term benefit, but why is that? How is that helping his function? It's helping to strengthen it by what? There's a big. It's sensory input. That's what it is. Your body is now trying to not use that side. It's not really even aware at the beginning for a lot of patients that it even has that side of their body. It's like not even there. That neglect, a lot of times, if it's affecting the right side, the patient will do everything, put everything to their left. They will completely ignore the right side, like it's not even part of their body. So if you have them bear weight on that side, it's sending that sensory input, like, hey, this arm is here. These muscles are here. This bone is here. It's working on all these different skills that you guys learned with the task analysis stuff, just by putting weight through it. It's sending so much signal to the brain, trying to wake it up and build the neural pathways to use that arm again. It's so beneficial to bear weight on affected extremities with strokes. But you have to do it safely, and they have to be supported. If they just have a flaccid arm, you can't put it out and say, okay, lean that way. They're going to fall. They could break their arm if they fall and twisted it the wrong way. You have to keep them supported until they get better core balance and all that stuff, then become more aware of that side. So that's what it actually looks like when you do weight bearing with a patient as an intervention. Okay? Are we good on that too? All right. I'm going to go over some cognitive strategies, and then we're going to take a couple-minute break because this is a lot of information today, and I don't want to, completely bombard you with it. The next is mirror box therapy. It's on page 853. Towards the end of the lecture, I'm going to show you a video of it too. But this is like having a patient stick their hand into that mirror box. Do you guys see the picture of it? What it looks like? And asking them to perform a movement, right? It is, let me, you know what? I'll just show you the video because it'll make more sense.
You can improve your arm use if you have hemiparesis from a stroke or maybe a brain injury. There are different ways to improve arm use. One is to try to use both arms together. talk about this in another Utah neurorehabilitation YouTube video. Another one is constraint-induced or force-use therapy. Today, I'll talk about mirror therapy as a way to improve arm use with hemiparesis after a stroke or brain injury. I'll introduce you to mirror therapy to show you it's a possibility. An occupational therapist can show you exactly how to do this. In mirror therapy, you put a mirror right in front of you. In therapy, they can use what's called a mirror box. You move your strong hand and watch it in the mirror. It looks like you're seeing your weaker hand move because you're seeing a mirror image of your hand. At the same time, work on doing the same movements with your weaker hand. This young man is using mirror therapy to improve his hemiparetic hand. Here, he's working to rotate his hand. In our brains, we have a mirror neuron system. This is turned on when we watch someone else perform an action or do something. It unconsciously imitates what we see, hear, or perceive. The reflection in the mirror tricks our brains into believing that the weaker hand is moving. When we watch the movement in the mirror, this stimulates our brains to move the weaker hand. As with any type of therapy to improve, you don't make changes overnight. It takes time and work. In other Utah neurorehabilitation videos, I talk about daily practice to improve.
All right.
Same time next week? Cool.
Of course, he had to come into the lecture, didn't he? All right, so with the mirror box therapy, that's not the right one. Do you see how that's a benefit? How it's more or less seeing his arm move in a normal pattern. He's trying, and now his brain is actually seeing his hand do that movement. See how that can be beneficial? It really helps build those pathways a lot. They'll do a lot of mirror box therapy, a lot in outpatient. Have you seen it in your facility before? Mirror box therapy is really important there. We don't have a mirror box over there. We have the big stand-up mirror that's also beneficial. It doesn't kind of work in the same way, but those are a little bit more common in like skilled nursing facilities. The last two things I want to talk about as far as approaches before we take our break is action observation. This is very simply watching somebody else do the task, whether you, another person, watching a video, whatever it be, having them watch how the task is done correctly and normally, and then asking them to do it. Okay, it gives them a mental image of what they're supposed to be doing. Now, you don't want to bring another stroke patient in and say, hey, look, they're able to do it. Now, you don't want to do that. Not comparison. You're giving them an example. Okay. And the mental practice, that is simply rehearsing it beforehand. That's like walking through all the steps of it. If they want to try a couple steps first, whatever they need to do to get ready to perform that task, is that mental practice. Okay. All right. Take you guys a 5-minute little brain break, and we will start the second part of this in just 5 minutes.
Chapters, are they in the one?
31, 32, and 33. And I'm going to postpone it from Wednesday to Thursday, and it'll be open through Saturday at 5 o'clock. The reason being, you guys aren't going to have class on Wednesday for the CPR stuff, and I'd like to use Thursday, the Jerry's class. What I'm going to do is I'm going to just double up the chapters tomorrow for 2:15, and we're going to use the regular 2:15 time on Thursday to practice stuff for 2:07. Okay? It'll be an all hands on day. We're not going to lecture at all. We're just going to go and practice stuff from the lab, have you guys come up with interventions. But I'll give you something to help you kind of gauge it. We'll get there.
You're gonna do a review for the exam?
If I have time, to be honest, I've not completely finished the exam yet either. So I've got to finish it today. If I have time, I absolutely will. Did anybody do anything fun over the weekend? No? Not a thing? You don't remember what you did this weekend? We stayed in all weekend long. Hey, we're just taking a brain break.
A brain break.
Yeah, we're taking a trick out of your playbook.
Everybody's moving.
Nobody's brain breaking.
I like the shape.
They're just chilling for a minute.
Sure.
I don't have the fun dice that makes them get up and do jumping jacks and stuff. I don't have those. I was asking, how much snow did you guys get? You got 4. We got a foot. Had a foot of snow. You got 9 inches. Where now you from Putnam County? Yeah. You had 9 inches too?
I just look at the top of it. I look at the top of my car.
It was crazy. How much did you get?
The dirt was going over the mud with the cheap, you know, bad measurement.
Our porches. Always good.
Mhm. Yeah. Yeah. Really? Yeah. We I walked over to my neighbor's house to play cards, and I came back and I thought, like when I was stepping into my yard, when I was coming home, I thought the snow was like 5-6 inches deep. It was not. It was a snowdrift, and it was like 2 feet, and I stepped and I totally slipped and fell. In midnight, and what was fun, I was literally walking across the street, so I wasn't like dressed warm. I was in shorts and Crocs, and I just fell in 2 feet of snow in shorts and Crocs, and it was a bad time.
Sounds like fun to me.
Oh, it was awful, and it was what 8 degrees, 9 degrees, so all that on top of it. I was not a happy camper, and I was helping, Carolyn move furniture and stuff, and I had popped a rib out of place. And so I went to the chiropractor on Friday, and I was like, first time I had not had any pain in like 2 weeks. And then I fell and hit my back, popped the same rib back out. But let me tell you this. I went to the chiropractor Friday, right? And I told him he's just really busy. I told him it was really hard to get in to see him. His office is always booked up. And he said, well, here, I'll just show you how to pop a rib back in place. I was like, I've gone to him for 10 years. I mean, I've known this dude forever. He's like, I'll just show you how to pop one in. It's like, okay. And he said, here, I have one that's out of place. I'll let you adjust me. It's like, what? So legit, he popped my rib into place, right? We're good. He lays down on the table. I was like, here, I'll show you how to do it. Sure enough, showed me right how to pop his rib back into place. I was like, I'd pay you all this money for this. But I was floored. And then Carolyn had a rib that was hurting her too. Did it to her, popped right back into place. I was like, this is wild. All this money. And that's all it was. Now I'm not gonna go cracking people's necks and stuff. They showed me just a simple way to pop a rib back, and I was like, wow, that worked. Pretty wild stuff.
People pop the ribs out. It's a normal
I
thing.
hurt my back when I was little, so my ribs pop out of place all the time. It's nothing for me to go and have 6 or 7 that are popped out.
Make your breathing hard when it happens.
Oh yeah, sucks. But all right, are you guys ready to jump back in? Let's go to page 855 in your books. So I want you guys to start thinking about what positioning looks like with patients that have a stroke. What, is it the same as everyone else? Are there special precautions that we need to take? What do you think with as far as positioning goes?
Protected arm needs to be protected.
The affected arm should be protected. Why? What have we talked about that is a huge risk factor for patients with flaccid extremities, particularly?
They don't have sensitivity.
Right, and they can hurt it. But what's a big support issue? We even taped for it. Sublux shoulders, huge risk. If somebody has a flaccid extremity, they're not, that joint, it'll pull out and there'll be that sublux shoulder. That's what we taught you guys how to tape for. So as far as positioning to try to avoid that, what would be, without, me showing you, what would be a good positioning device or just regular position that you could put somebody in that will help avoid that? A pillow under their arm. Okay. Do you want it right here? What is it? Like right here? Okay. So give me a practical. All right. As long as it's supported. So one thing I tell a lot of patients is if you're sitting at home on your couch, put a pillow up there. Keep your arm elevated because you don't want that arm pulling out. Gravity will pull it out. If it's just they're dangling, they're going to injure themselves. You're going to have and if you try to do passive range of motion with a subluxed shoulder, super painful. That's a hill that you don't need to climb. It already doesn't work. You don't need to make it painful too. What about a wheelchair? What is some of the stuff that we've shown you? And I'll show you this again when we go to the lab on either maybe today or Thursday. That big armrest, that's an arm trough. That gives the shoulder a lot of support. That's a huge and very common adaptation to wheelchairs that stroke patients have. What about when they're in bed? Is there any kind of special precautions you should take with positioning? Okay. Yeah, I hadn't thought of that, but yeah, sure. Yeah, that would be one. Either. A lot of people have hospital beds at home when they're doing rehab. A lot of people do. Some don't, but a lot of people get sent home with them. What's another positioning thing you should be aware of for bed? Okay. So would you tell a patient to lay on their affected side? Would you? Why wouldn't you?
They cut off circulation on accident because they can't feel.
Okay. So I'm not saying I don't want them to sleep on it, but would you tell them to occasionally lay on their side that's affected? Okay. It's weight bearing. Absolutely. One of the most beneficial things, like I was telling you guys, is weight bearing. So you're just laying on that, you watching a TV show, lay on that side okay? When the next episode you're binge watching, flip over to the other side. Now, when you put a patient in bed and say they are a side sleeper, okay, would it be beneficial to put your patient on their side that is affected or unaffected when they're sleeping at night? On the unaffected side. Anybody disagree with her? This takes a little bit of outside thinking. This goes against a lot of the stuff you guys are.
Like you can mess up somebody's circulation or something. Because like if my arm falls asleep while I'm sleeping on it, I'm gonna know it.
Right.
They're not.
Yes and no, depending on the person, depending on what was affected. You have to have what first? What's the one thing that's going to make this no or go? You hinted around it. They said they couldn't feel it or could. They have to have sensation. If they have sensation, would you put the patient on the affected side? Okay, what would be let me back up. What would be a benefit of putting them on the affected side?
They were not laying in there, but they were like flail around, so at least it's like controlled.
Okay.
In place.
If you can only move your right arm, right, and I lay you on your right arm, how good are you going to be at doing things for yourself?
Yeah.
How good are you going to be for doing things for yourself?
Yeah.
If I put you on the only arm and the only leg that you can use, if I lay you on that side, I mean, what are you going to be able to do? Can you reach your remote? Can you reach your drink? Really important, can you reach your call bell? All right. So it kind of goes against that whole idea of the pressure sore stuff that we've talked about. They are at risk for pressure sores, you're right. But in order to manage this properly, they have to be able to use whatever side that they have, in order to reach their call bell, get their water, get a drink, eat, whatever it be, change the channel. They have to be able to do that stuff. So it's okay if they're laying on that affected side, but you have to teach them and nursing staff proper weight stuff, right? You don't want them to be laying on it for too long. If you need to roll over, get some blood circulation for a few minutes and roll back, it's okay. Remember, you're not working, even if it's a paralyzed side, they still have a side that they can use. But it depends on your patient. If they don't have sensation, you need to err with a lot more caution. Okay? Like I said, with every single stroke patient, they react, they're different. They're all different. All have different effects. There are some commonalities, but you're going to find something different with all of them. All right, so we've talked about bed and wheelchair. What about standing or walking? Well, how would you position the affected arm in that situation? Just let it dangle? An arm sling. A good one. What's another one? So if you're transferring, I think we talked about this when we did transfers. If you're transferring the patient, you have a gait belt. Put them over. What about sticking that affected arm slightly in the gait belt? You don't want to put it like this, but like putting it where it can be supported. That's another big help. Basically, with standing is don't let it dangle. That's it. Don't let it dangle.
Are you saying just putting a few fingers in the gate belt?
Yeah, you don't want to. I don't ever go really past the wrist. But I've used that trick a lot to keep it from dangling if we don't have an arm sling or. We do have a give more sling, don't we? We'll have to teach them that on Thursday. Those are just so uncommon. A lot of facilities, they have just your standard broken arm sling and say use it for everything. All right. So let's talk about self-feeding, eating and swallowing. What roles do we play in self-feeding as far as positioning goes? How do you eat? Do you eat laying flat on the bed? No. How do you eat? Huh? Sitting up at 90. Why is that important? Okay, so if you have like dysphagia or whatever swallowing disorder may be, that makes it even harder. So what do you need to help you with that swallow or with just getting the food down? Gravity. Gravity helps a lot with swallowing. It's your friend when it comes to self-feeding and strokes. There's a few techniques that I want to teach you guys that will help assist with swallowing. One of them is the chin tuck, okay? And that's nothing more than exactly what it sounds like. Chin tuck. Why does that help? What are you doing when you tuck your chin? Think about it. Kinda pushing food. Cassie, what are you doing with the chin tuck? What'd you say? Okay, you're opening, but what are you also kind of shutting? Right, you're kind of closing your airway a little bit, opening it up so it can help initiate this swallow, get it down a little bit better. The next one is the head turn. This is similar to the chin tuck, but the head is slightly turned. And it also helps to decrease aspiration. Everybody remembers what aspiration is from the feeding lectures, where they take food will get into the airway and get down and cause pneumonia and all that. Cool. I can never pronounce this right. It's called the Mendelssohn maneuver. I can never pronounce this correctly. But anyway, it's where you have the client push their tongue really hard into the top in the palate, and it helps initiate a swallow. Okay? Those are three just, simple kind of help with swallowing and help with reduce aspiration techniques as far as eating goes. As one big thing that we're going to work on that's more important, or more common, is adaptive equipment with stroke patients. You may need to use a rocker knife. Have I ever shown you guys what that was? It has a handle and it just rocks back and forth to cut meats because they don't have their other hand to stab the steak and cut it. They may have to use a rocker knife to cut it. There's a lot of different pieces of adaptive equipment for stroke recovery and eating. A scoop plate. They don't have, the coordination to get there. That's another really common one. If they have poor grip, you could do the built-up handles. I mean, it really is endless with ideas and possibilities with adaptive equipment and strokes. I can't think of anything. Is there anything else you would mention? Another piece of adaptive equipment? There's just so much that is out there for stroke recovery. I mean, half the book that I showed you guys, you could justify for just some type of stroke recovery. But anyhow, I can't think of anything else. All right, so somatosensory interventions. So what a somatosensory intervention is refers to sensation coming through the skin, joints, and muscles. And this is a lot of sensations that we tend to forget about, like vibrations, firm and light touch, pressure, texture, stereognosis skills, all of that. People with strokes, it's been estimated from 11 to 85%, but I definitely go toward the higher end of it, stroke patients that definitely have sensory issues. Definitely, in my experience, if they have a flaccid extremity, the sensation is 99% of the time it's affected. There are three main goals or three principles with somatosensory interventions, and you guys definitely need to know these, okay? The first one is you need to use goal-directed attentive exploration. What that means is there needs to be a clear something. And I'm going to break this down with an intervention in a second. This can make a lot more sense. But there needs to be a clear goal of whatever sensory information or sensory intervention you're doing. The second is normal touch sensation is the second principle. It needs to be some type of a normal thing. Okay? And then the last one is there needs to be some type of a graded progression. Okay? One thing you're going to see in every single therapy gym in the United States is a rice bin or a bean bin or whatever it is, and it has little things in it that the patient has to pick out. Okay, a lot of OT practitioners will use that just for fine motor stuff, but there's a lot of sensory stuff. They're actually called sensory bins in traditional sense. Okay, what the goal part of it would be, I want you to pick these items out of the rice. Okay. The second part of that would be the normal touch. That's just reaching into something and trying to find it. That's a normal sensation, right? Reaching into your pocket, pulling something out, whatever, reaching into a drawer and looking and picking something out. That's a normal thing, right? And then the graded progression of that would be either making something smaller, making something bigger, making it a different texture, something. Most of the time, it's whatever you can find that's small in the therapy gym and they throw it in there. It'll have pennies and pegs and whatever it be. There'll be all kinds of stuff in these bins. But the goal is reaching in and getting as many things out as you can.
That's so easy to grade up and down.
Oh, yeah.
Because, you can just, I've had patients before who could not tolerate the sensation of the rice on their hand.
Mm-hmm.
But they could tolerate beans.
Yeah.
Or they could tolerate a bucket full of cotton balls.
Something.
Something.
Whatever it is.
It's grade it up and
you could add wrist weights to them and have them do it that way after they get so far. There's a lot of stuff that you can do with sensory bins. They're so common. I have one in the back of my car for home health. Everyone has one. Water's a big one. Okay, so that's for sensory stuff. Let's talk about some cognitive deficits. The first one I want to talk about is attention impairments. So what is attention in a nutshell? Maggie, what's attention? Okay. I want to start this off by saying with cognitive interventions that the goal of this is identifying what they can do, what they can't do, what their strengths are, and what their limitations are. So for attention, we're going to break that down into two different types. Okay. The first one is you need to focus on improving or remediating underlying attentional deficits. So trying to retain or gain. Okay. The second part of attention, addressing attention deficits is learning comp strategies. Okay. So there's two different ways to break that down with attention. First one, again, was remediating skills or learning that skill again in the normal way. The second would be a cognitive or a comp strategy. Okay. The next one we're going to talk about is memory. This is using stuff like, well, I'll let you tell me. What would be a good memory intervention, Jennifer? Somebody has poor memory, let's say for this short term. What can you think of would help with memory? Anything. You just have poor short-term memory because your patient has had a stroke. They have poor short-term memory. What would be a good intervention? Absolutely. That's a good short-term memory intervention. I've had patients do memory games before. What, like the matching thing, like where you flip one over, flip another one over, and you got to flip them back. You know what I mean? That kind of thing. What's another good memory intervention? Faith, what would you do?
Maybe like have out 3 or 4 different items depending on their level, and then take them away and see if they can figure it out.
Okay, sure. Chunking, teaching them a way to help remember information in an easier way, like the phone number thing. Very good. Very good. All right, so let's talk about executive function. It's another big area that is affected. So there's 4 broad categories for interventions. The first one is environmental modifications. Second is comp strategies. Third is task-specific training. And 4 is training in metacognitive strategies. That's like the recall strategy stuff. Okay?
Wait, so out of the you just mentioned, is the third one comp strats?
Yes. Yes. Sorry, I didn't even realize those were up there. I was going off what I wrote. My bad. So the first one is environmental management. So how does your environment play into executive function? What is executive function? Isaiah, what's executive function? Higher level thinking. So what does your environment have to do with that?
It can make it where you don't have to think about tasks that you're doing.
Okay. What would be an environment modification you could do? Let's stick with an ADL so it'll help make this examples a little bit easier. Let's say brushing their teeth. Okay. They don't remember that executive function of I need to get up in the morning, I need to brush my teeth. Okay. They don't remember how to do it, why it's important, all that stuff. What would be an environment intervention or an environment-based intervention you could do to help them with that?
Easy ones are either sticky note or dry erase on the mirror bathroom.
Perfect.
I like the adaptive equipment the other student made in the orientation board.
Yeah.
They made.
Yeah.
I like that too.
Okay.
Say like morning.
So some type of a visual cue, a schedule, anything like that. Very good. All right. So comp strategies. What would be a comp strategy, Allison? We'll stick with that same example, the brushing the teeth. Someone want to help her out? What would be a comp strategy to help somebody remember, or not remember, but understand the process of I need to wake up in the morning and brush my teeth? The whole idea of oral hygiene.
Just like make them everything they need to do.
Yeah, I think that goes along more of an environmental thing though, because that's like a visual post or cue, a poster, an orientation board, all of that. This one's a little bit harder. Lindsay, what are you thinking? Okay.
I don't know. Yeah.
Thinking of something. Absolutely, you could color code. You know, you could tie it in with the environmental thing. Like you could say green is what you do in the morning. This is just throwing that out there. Okay, that could be your environment part. Comp strategy part of that is taking and painting the toothbrush green or putting green tape around it or whatever. That way they see green, it means morning routine, brush teeth. Make sense? Kinda. Faith doesn't look like she's buying
It's
it.
a little complicated.
Could be, but if you're learning something from brand new, remember you're talking about, you got to take out your aspect of, you know that in the morning you get up and you have to brush your teeth, right? You're teaching this to somebody who can't remember in the morning what they're supposed to do at all. So how do you help them? The tape itself would be, but the comp strategy is the green to green. That makes sense? And that you're not going to use, and I was going to get to the point in a second, it's a group effort. It's not a, you use this environmental modification and then that's it. It's that it plays off of each other. It's a team. I was getting that, but yes, that's what it is. All right, so task-specific training. Don't overthink that one at all, Maggie. What is a task-specific training? Teaching them how to brush your teeth. Right. That would be a task specific. Very good. And then the training in metacognitive strategies or the recall strategies. Cassidy, what's a recall strategy? Okay. So what's a strategy to help you do that? That's recall, but what's a strategy for that? Okay. That's fine. All right. Another one recall strategy you could even I did this with one patient and she loved it. It was her we took her favorite song and kind of rewrote lyrics to it to help her remember her morning routine. That's a good recall strategy. You know, I don't even remember the song and I'm not going to sing it, but it was we wrote it like it, you know, this is what we do in the morning, this is, you know, the next part. It takes a lot more work to do something like that, but it worked for her. You can do a checkoff list. That's more of an environment modification. That if it's an outside thing that they're using, that's an environment modification, which is really, really, really common. That's why it's hard to get away from those, because that's exactly where our mind goes, is an environment modification, because they're so common and they work well. All right. Any questions on cognitive impairment? All right. Impairment in self-awareness or insight. So if somebody has poor self-awareness or insight, what it is meaning is that they are like in denial of it, which is really, really common. A lot of patients will be like, oh, I'm fine. I'm good to go home, but they can't use that side of their body. You wouldn't think that that would be an issue, but it is. And convincing them that, listen, you're not okay. You are sick. You need to be here for rehab. That diagnosis or that is called agnosia. And no, I said that wrong. And anosognosia. ANOSOGNOSIA. That is the denial that there's any kind of weakness or impairment at all. There is a difference in statistics, though. It's 28 to 85% of individuals with a right side stroke and 17% with a left side stroke. So it is a difference depending on where it is, but it is common that patients will say, you know, I'm fine, I'm good, I don't need your help. Why am I even doing this? Sometimes they become very argumentative and They don't want to work with you in therapy and stuff, all because they don't really feel like they need to be there and they can't use one side of their body. So, all right, these we've talked about before. I just want to make sure you guys know what they are. Aphasia, that is a communication disorder where they have problems with speaking, listening, reading, and writing. It's not a sensory disorder. They just simply, they can't like speak or listen. They're not really understanding. My grandma had a stroke too, and hers was very severe, and she had a lot of memory stuff. She had a lot of personality stuff. She had a lot of physical stuff happen. But she would always say, no matter what, the only word she could say was "backa," and every time that someone walked in the room, you asked her a question, her answer was "backa, backa, 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 backa." That's what she said all the time. That is aphasia. Okay. Next is apraxia. That is well, first, what is praxis skills? Lindsay, what's praxis? It's like playing motor movements, praxis. So apraxia would be difficulty with doing that, right? Okay. And then lastly is agnosia. This is the ability that, or the loss of the ability to recognize objects, faces, voices, places, all of that stuff. One really cool intervention I did with my dad was as soon as he woke up from his stroke, I was getting common items and telling him to tell me what they were. And then I would get more complex, and then I would get to like pictures of people and say, who is this? Who is this? Who is this? And then I would get, further out from the family and closer relatives and stuff. I would go to people he has met 2 or 3 times and ask them what their name is as it got further out. Okay. And it helps build those skills of recognizing. Okay. We're almost done, I promise. Then you have the visual spatial perceptual impairments. A visual field deficit, that is a loss in some field of vision. It's, could be upper, lower, left, right, whatever. That is a deficit of that. And this is all things that can happen with a stroke. So you may have somebody who has left side, or you think is presenting with left side neglect, but really they lost the left side vision or visual field. So they might not be neglecting it, they might not see it. You have to figure out what the issue is. Because a lot of that stuff in acute will get missed. You find out these deficits after the fact when they're going through rehab and you have them try to do some ADL or IDL, and you're like, you're not using, your left side near as much as what, you should. And then you find out later, oh, they couldn't even see it. It wasn't that they didn't know that it was there. They couldn't see that side. All right, so diplopia is double vision. The visual spatial deficit is where they're unable to recognize patterns. And then unilateral neglect is not responding at all to stimuli on one side. That goes along with that the actual neglect portion of it, that left side, right side neglect. Okay, so can a person have a visuospatial perceptual impairment and not know it? Okay. Yeah, that would be like a visual field deficit. But yes, you're right. That is a one. So they can have it, but how do they not realize that they're having a deficit? How do they not know? Allison, how do they not know? Exactly. They start compensating. Your body's not, or your body is very adaptive. It wants to try to just do the task normally. It's going to try some way to compensate for it, and they're not even going to realize it's there. So how do you help them realize that there's a deficit? They don't even know. Maggie, how do you help them? Yeah. Yeah. For the visual field deficit, here's my coffee cup on the right side. You say, hey, grab that coffee cup on the right side, but don't turn your head. I can't see it, but it's on the right side, and then have them do some scanning and figure it out. Good. All right, so some psychological stuff. Anxiety and depression are extremely, extremely prevalent in stroke patients. Anxiety is normally what's gearing it or what's keeping it going is the fear that they're going to have another stroke. Depression is, I'm sad, I have this, it's exactly what you think of, but because they've lost movement, they've lost function, they've lost personality. My dad always would tell us, I just want to be the person I was before, but he doesn't know who that person is. So we'd have to reassure him, like, hey, you are doing this just like you used to, just like you used to, just like you used to. Reassuring him, letting him know that really helped his depression was knowing that he is becoming the person he was before, step by step. Okay. Some other disciplines that need to be involved for sure is a psychiatrist or a psychologist. If they have the stroke and anxiety or the depression and anxiety from it, those people really do need to be involved in treatment because you're already battling, all these other symptoms that we've talked about. I mean, there's hundreds of different things. You're already trying to fight that. You need to bring in some other people to help fight that battle. All right, so instead of going over interventions for ADLs and stuff like that, we're going to practice that stuff together. But, yeah, there it is. I want to go over one more thing. In addition to the person with the CVA, the OTA must address the needs and concerns of the caregiver. This is so important, guys, that this is a rapid, sudden thing. Think about that video that I showed you at the beginning of class. How scared could you possibly be then you were sitting at your dining room table having a normal dinner like you always had, and all of a sudden, boom, there's a face droop, they lose one side of their body, on the way to the hospital, life changed in the blink of an eye. That's exactly how it was with my dad. I took my mom on a trip to Tennessee. He called us and asked us what time that we would be home. He was at work. And literally the second we pulled in the driveway at my house, his boss called and said he was unconscious, that they were sending him to the hospital. And literally in that blink of an eye, his entire world was flipped upside down, and so was my mom's. My mom will tell you that one of the hardest things is that her husband's not there. Like the guy that she had been married to for 30 odd years is no longer there. That person's personality is gone. The laughy, funny, goofy guy that he always was gone. He was silent. He had no emotion. My dad would sit with a very flat affect and just stare off into the world, have no idea what was going on, and was normal the day before. I mean, it's a totally life-altering event, and it changes everything. But what is hopeful, and I'll tell you guys this, and I've treated more stroke patients than anything I've ever treated. The best outlook for patients with stroke recovery is if the patient wants to get better and if the caregiver, they have good support. If the patient has good support and the patient is determined to get better, 9 times out of 10, you have a better outcome. There are outliers. Sometimes people don't get better no matter what you do. But the overwhelming majority, if you have the person determined and on board with your treatment, you've already fought half the battle. Okay? Also, I need to mention that when stroke recovery, you have about 8-ish months to a year is normally peak. Where they're at after a stroke, after about 8 to 12 months, is normally as far as they're going to get, as far as recovering, like from the brain, building those neural pathways, all that stuff I was talking about, 8 to 10 months-ish. There are outliers to that, but that's a rough statistic. Okay? So the beginning part of therapy, that first year of therapy, has to be nonstop. I mean, constant. I mean, my dad's back to, he works a full-time job. He takes care of himself. He's completely fine. He's pretty much back to his normal self that he was prior to, but he still has a little bit of personality differences. But other than that, he's pretty much the exact same person he was before. I could not imagine how his recovery would have been if he would have, not had a nurse, my mom, and me at home to take care of him and help rehab him. But it really takes a lot of support. It takes a lot of support to get there. Okay. All right. Now I'm gonna go ahead and stop the recording.